Shinagawa. Shibo is the Associate Director of Infectious Diseases at the Association of Asian Pacific Community Health Organizations, or APCHO, where she leads programs advancing health equity for Asian Americans, Native Hawaiians, and Pacific Islanders. As Project Director of the TB Elimination Alliance, or TEA, she oversees initiatives addressing TB, hepatitis B, and other infectious disease priorities, working closely with public health departments, federally qualified health centers, excuse me, and community-based organizations. She also manages APCHO's cooperative agreement with the CDC's Division of TB Elimination and represents APCHO on national and state TB advisory bodies. She holds an MS in Global Health Policy and Management from Brandeis University, a BA in Sociology from Mills College, and is PMP certified. She lives in San Francisco with her partner and twin girls. So Chibo, please take it away. And Chibo will be introducing our next speaker as well. Thank you very much for speaking.
Thank you very much, Bijan, and thank you all so much for joining us, in commemoration of World TB Day. It's a real joy to be here and to get to see all of you and learn more about your TB Echo and just to have this collaborative space. I think Bijan shared a lot of, great bio, and I can just touch on a little bit more on APCHO and then our TB Elimination Alliance and introduce our guest speaker, Jean-Jacques Kayembe from the Congolese United Foundation. So APCHO is known as the Association of Asian Pacific Community Health Organizations. So we promote advocacy, collaboration, and leadership to improve the health of Asian Americans, Native Hawaiians, and Pacific Islanders. We are a membership organization, national. We have about maybe 46-ish of community health centers in both the continental US and the US affiliated Pacific Islands. And we were created as our vision is to be a national leader and critical voice for Asian Americans, Native Hawaiians, and Pacific Islanders. And our mission is to dedicate promotion of advocacy, collaboration, and leadership. And through APCHO, we actually are we have a collaborative project funded by the Division of Tuberculosis Elimination, known as the Tuberculosis Elimination Alliance, either TEA or we just call it T. And it's led by steering committee partners, the Asian Pacific Islander American Health Forum, the Association APCHO, Hepatitis B Foundation, and our project Hepatitis B United, and then Stop TB USA. So our national program supporting the elimination of tuberculosis, really, I think, uplifting and connecting, community-based organizations and uplifting that important work. And so through the TB Elimination Alliance, we have our mini grant program. And so our mini grant program, we provide funding each year to CBOs. We're in our second cycle of mini grant funding. And we're in year 2 of our mini grant program for the second cycle, but we've had I think it's been about 6 years now of mini grant funding, over $1 million distributed nationally to CBOs, CHCs, and public health departments. And this year, we funded over 10 mini grant organizations. We funded 10 mini grant organizations, and Congolese United Foundation is one of them. And so just sharing a little bit more about the work we do with our mini grant program. We want to make sure that each project is aligned with boosting community understanding, expanding access to care, engaging and educating innovative ways, and strengthening provider practices and building local capacity. So these mini grant projects are very much in line with a lot of the work that you all do, and I think will be a great topic for discussion for today. All right, I am going to introduce our guest speaker, and our guest speaker is Jean-Jacques Kayembe. He is a founder of the Congolese United Foundation and a public health leader committed to advancing health equity for African, immigrant, and refugee communities. He works closely with the public health, Seattle and King County PHSKC TB program, and regional partners to reduce the burden of tuberculosis among immigrant populations through culturally responsive outreach, language access, and community-based prevention efforts. He also serves as vice chair of the Immunization Action Coalition of Washington, championing prevention, vaccine equity, and community-driven public health initiatives. All right, Jean-Jacques, we're so excited for your presentation. Take it away.
Thank you so much, Shibo, and thank you for Bijan and Lina for having us here. Hi, everybody. My name is Jean-Jacques Kayembe. I use he, him pronoun, and I will share a little more about the work we're doing. Can you see my screen correctly?
Yes.
Okay, today we'll talk about the TB screening gaps and community engagement efforts by the Congolese United Foundation in King County, Washington. So I have non-conflict of interest to share today, and our learning objectives are three. The first one is to provide the HPO and Congolese United Foundation background work on community engagement and funding at the local level. The second learning objective today is to summarize the gap in TB screening among Angola and Congolese communities in Washington State, and particularly in King County. And also the third learning objective is to consider the project ongoing efforts and understand the challenge of screening and linkage to care among newly arrived immigrant and refugee in King County. And those are some key terminology for today's presentation. A little bit about Congolese United Foundation. Congolese United Foundation is a community-based organization based in Seattle, serving Congolese, but also African immigrant communities. We focus more on community engagement, education outreach, and try to bridge gap to reduce the burden of communicable disease in King County and in Washington State. And we're talking about TB because TB is an important topic in the Congolese community because TB remains one of the major global health challenge in the world. And in 2024, we have estimated, WHO has estimated 10.7 million people having TB, and the incidence rate was 131 cases per 100,000 people. And this is really an important issue. As you can see, the distribution, 25% of the people having TB around the world are located in Africa. And when you look at the US, the burden is not even evenly distributed. As you can see, most of the case of TB are located, on non-US born population that represent 15.5 on the 100 case compared to the US born with less than 100K population. And look at here in King County in Washington State, we have seen a concerning uptrend of TB cases reported. In 2024, we have reported 257 cases of TB. That was an increase from the previous year, 2024, of 17%. And the burden of TB are concentrated in King County, which is the focal point of our TB effort in King County. And one of the key factors we've seen on recent reported cases is among newly arrived immigrant and asylum seeker. In the past 5 years, this number of immigrant and asylum seeker are mostly from the Democratic Republic of Congo, DRC, and Angola. And that's why our focus on the Congolese United Foundation was to really educate the community and also understand why the screening was not as important in this community when the burden is really important. As you can see, the burden of TB in Angola and DRC is among the highest in Africa and in the world. In Angola, for instance, they have 339 cases reported over 100,000 people, when in DRC, the incidence ranged between 315 and 321 cases. So one of the main questions is why we focus on newly arrived immigrant and refugees. That's a legitimate question because, of course, the newly arrived immigrant from DRC and Angola represent the population with higher burden of TB. And if we want to be serious about TB elimination, we need to focus upstream, which is identifying and treating latent TB infection, or LTBI. And this is critical because many of those people don't have clinical or other active symptoms, and they live in the community and they can easily spread the disease. That's why Congolese United Foundation has been working really hard with partners in King County to see how we can target those community and provide not only education, but also link those people to service. But newly arrived are really important because those newly arrived represent a key window for us to not only do outreach, education, and also have them navigate the healthcare system, because the impact of the on-screen latent TB in community is far more than just one individual, because one on-screen people can spread the disease to the community. And that's why we have adopted a community center engagement to reach community and try to reduce the burden. So we have asked this question: why people are truly willing to be screened? Because that was the really challenging question we had. And one of them, it's because sometimes the screening is available, but it was not intentionally designed and built so that it can be culturally well understood by the community. That's why I want to fill this gap by not only reaching out to the community concerned by providing education, outreach, and also providing resources that are available in King County. Those two pictures demonstrate the challenge we have. On the far right, this is the encampment center that was opened in early February 2024 in Kent. And on the far down, there's the encampment, the famous encampment in Takwila that was well known in the news. This camping was dismantled, but people are still living in Riverton Church when they receive support from many community organizations. So our work around TB elimination have been two phases, and we started this program in back early 2024 when we realized the need to provide education based on the insight from Public Health Sierra King County TB program. So we started our program in 2024 in two phases. The first phase was the active outreach and education, and the second phase is to go deep on evaluation and reframing our approach into dissemination. So the first one was designed to provide outreach, workshop, community engagement. This first phase focused on targeting outreach, first on large community events, and then we quickly realized that those large community events were not as successful as we thought at first. So we redesigned our approach to target now faith-based organization and trust community because of the challenge of immigration status of many people want to serve. And our primary population was first people from the Democratic Republic of Congo and Angola, because the influx of those population in the greater Seattle area. And to ensure effective communication, we center our approach into using primary language as a way of communicating to break the barrier, because most of those people have language other than English. So we design our approach creating material in French, in Lingala, in Swahili, and Portuguese, which was critical to build trust in the community for our efforts. And also through workshop and direct communication, we have identified key barriers to TB screening, especially latent TB screening. For instance, I will share an anecdote. In 2024, someone was diagnosed for latent TB, and he went to a church telling his friends that he was diagnosed for sleeping TB, and everybody was laughing because latent TB can be translated in Lingala as sleeping TB, which is not really accurate way to describe the disease. And many people from the Congolese community don't know about latent TB. For them, you have TB or you don't have TB. So for that person explaining that he have sleeping TB and they give only 2 pills to take for 4 months, it was a paradox, because many people from the DRC understand that TB is a deadly disease. When you get it, you will receive up to 5 medications to take every day for at least 7 to 9 months. And have someone in the community telling them about sleeping TB, they were not concerned. They were not really convinced. So we step in and try to break those explanations down to make them understand, okay, in fact, there is two types of TB. One is active TB and one is called latent TB. But because in the community, there was not a term that can well explain latent TB infection, there was a challenge to convince people and to adhere to our screening and outreach efforts. But through continuing education and empowerment using pastors and faith leaders, we're able to break this cycle and be able to convince and explain TB to many people. We have also included some outreach in different places, especially congregate places like Mary's Place, Thrive International, and all other community organizations serving a newly arrived immigrant and asylum seeker, especially in South King County. So this is one of the flyer we've created explaining the TB in the community. The challenge was really to create a material that not only contain enough information, but relevant information so that people can understand. I just put a screenshot of the material we created in English to show you that how complex was to summarize all those complex evidence and material information around TB to make it not only easily understandable, but also digestible to the community. So we wanted to highlight two facts: the big difference between active and latent TB, latent tuberculosis, but also resource for them where to know and who to contact if they need more information. So for us, the goal was not only to provide information, but also to link them to services. So following the outreach and education sessions, we have conducted the Identify Community Survey to better understand how to engage the population. The goal for us was to assess the knowledge, perception, and understanding of TB and latent TB, as well to get deep inside of the real-world barrier those people are facing. We know from experience that many people not speaking language and not speaking English have the language barrier to access services. And also know that many people coming from DRC and Angola don't have essential health services, but coming here, it was not easy for them to navigate the complex US healthcare system. But beyond those already known information, we want to understand why, particularly those immigrants, asylum seekers, had a challenge, even though they have the opportunity to be screened on site. Many times King County TB program went in Riverton to screen people, but why those people were not as engaged as for other screening events we have organized in the past. So our effort will focus only on newly arrived immigrants because, like I said in the beginning, that was the unique window of opportunity to catch those people, knowing that they came from an endemic country of TB, give them an opportunity to be screened, and so that those people with test positive can be linked to service and for appropriate care. So during this ongoing effort of outreach, we have conduct 136 survey with participants willing to participate in the survey, because one of the challenge also is to have people participate in the survey. They were they volunteer to come to the events. They want to learn more by participating on the really filling the survey and respond to our question was another challenge. So we try to incentivize some of the people so that they can be really fully engaged, so that we can get the bottom why those people are not didn't want to be screened for TB, especially knowing that the resources were available and the follow-up was also available and other resources available for those people to be screened. So based on the survey, we almost 30% of the respondents report having a temporary status. That was really a critical element for us, because having a temporary status, many of them don't have a stable housing, not have a related transportation, and that could explain why those people could not access service when needed, because sometimes they're moving from one location to another because there is a house placement and people need to move from one location in Taquila and sometimes go to Linwood or maybe go down to Tacoma. So that was the challenge for them to navigate the system. Also, most of the people predominantly have the age was around 40s, and many have families. So that gives a good understanding of the dynamic of this population, because there was family centered. And that's why it was important to screen those people, because if family member, one person from the household had an active TB, it can spread to the entire family and to the spread to the community, because most of those people gather every Sunday to church in the church to worship. So it was important for us to catch those early cases and lead them to care. And also more than half of participants were from the DRC, and half of them were from Angola, and 30% of the people, some of them were US citizen and have a green card order. But the interesting fact is 75 of those people having a language of care other than English. That was the key for us to see how can we break down those messages and translate them to the way that people not only understand, also adhere to the message and follow up for more resources and services. Also, another key element from the survey was the fear related to the immigration status. And one for almost 25% of the people said they were afraid for screening because they believe the screening for TB will affect their immigration status. Despite the fact we explained many times, and people that was high opening when you look at the survey result, that many people were afraid to seek screening because they heard from other people that being tested positive for TB will affect and impact negatively your immigration status, which is not true. And that's for us was a key element to emphasize really on to differentiate how a legal status doesn't impact someone's situation when it comes to care and services. And also half of the people uh, were aware that the TB care service were available, but they avoid screening due to the concern that maybe in a hospital, the hospital will share the information to the legal authority, and that will negatively impact their care. That was really an interesting learning lesson for us, knowing that people were aware that service is available, of course, due to many outreach and on-site visit that TB program and us have done in different asylum sites. But despite this information and connection to services, many people still believe that the hospital system or the system in place could share the information. And that's one of the reasons they did not seek screening, even interest into doing screening, even when the service was provided on site. Another metric we've learned from this, it's about understanding care navigation. More than half respondents report that they do not receive TB-real information in their language or in a language they could understand. Most of the language resource available mostly were in French, but a high level French, so that people, even those who can understand French, could not really understand fully. So the challenge for us was not only to translate those material, but to make it at a third level grade reading so that people can understand. And even that, some people of old age could not read French or Lingala. So we create some small videos to be able to share the information. That's how nitty-gritty we went to, and I really want to appreciate the partnership we had with Ethnomed from Harborview Medical Center. We have us create those PSS videos in French and Lingala so that people can better understand, because by sharing the information, even in French and Lingala, some people still have issue understanding the content and the next step to take for their health. So as one of the results, 20% of people report they have a language barrier. One of the reasons why they didn't seek care because they didn't understand the process. And sometimes people have to rely on skin tests when the recommendation have changed and they didn't understand what was the difference. And there was a lot of doubt about the screening process as well. So both from this key finding, what we have noticed is first that language was a structural barrier for those people to access service, especially people from the Democratic Republic of Congo and Angola, because the materials available were not designed in a way that they can really understand the process or understand the disease itself. Since, for instance, for latent TB, there were not clear material to explain why the difference and what was important for people with latent TB to start treatment. Because for them, when you have a latent TB, you are sleeping, what they call sleeping TB, you cannot, you're fine. You don't need a treatment. And through our education, we remind them, we make them understand that people with latent TB are at greater risk to spread the disease, and this disease can be be activated to be active. So those people need to be screened and put into treatment. And also our finding revealed a lot of challenge. Most important ones that came a lot was immigration-related fear that affects screening and linkage to service, because more than half of the people have a temporary status in the US, and they didn't feel comfortable to come forward even to seek screening, because knowing that healthcare system somehow uh, didn't offer guarantee that the information would not be shared, they were not comfortable coming forward to be screened, or for those who be screened and test positive to continue the treatment. There was a lot of cases of the loss of follow-up because they didn't trust the healthcare system. And also, one of the challenge was also the complexity of care system in the US, because many people coming from DRC and Angola, first the treatment program DRC and Angola is to the national program and the DOT approach, and it's free. And many people here, even when they go for screening, they ask information about the insurance and all the different information that they don't necessarily ask many people in Congo and Angola. And that was another key element that stopped those people to come forward and seek screening and be linked to services. And building on that phase one, we realized that the result we received was great, but we need to understand more and picture why specifically those people face challenges. And we decided the County3 program to go a little bit deeper on this approach and reach out to those who have been screened, test, started treatment, or stopped the treatment to understand the barrier across the care cascade from screening to treatment, either treatment completion, loss of follow-up, or like refusal of treatment. And our goal is to expand and strengthen the community intervention while looking at what key elements can we learn from those people who went to the treatment and use those elements to refine our approach and also to propose other solutions to increase uptake and to make people complete their treatment, because the goal for us is to have those people get screened and test positive for latent TB to continue and finish their treatment. And this will hopefully help us really get a better picture of the situation in among, especially Congolese, but also by extrapolation to the rest of newly arrived immigrant community in King County, and see how we can refine our approach to our interventions. So one key component is to get experience from those people who went through the treatment, like I said, and we plan to conduct a semi-structural interview. We have 46 candidates that are willing to be assessed, and we were planning now with King County to see how we can regroup those people based on location, because some of the people are now look at a different location, some of them up north, some of them in Tacoma. So we're trying to see how we can create some cluster of people and be able to reach out to those people and continue this deep dive understanding what was the challenge they face as they go through this TB screening and treatment. And the goal for us is to learn from them and also to see what we can do to help them further, especially those who stop their treatment, because the goal is to reconnect those people and make sure they complete their treatment. So we hope, based on the result of a qualitative a deep dive intervention, to refine our approach, but also propose some of the solution to see how we can improve how we screen people here in King County, because the goal for us to create a process this is more personalized, one-on-one approach, which is culturally relevant and also meeting the need of this population. Because right now, the people we are targeting are having a temporary status. It's the goal for us is to try to compare, to balance between their safety and their priority, because most of the people now, their priority is, safety, housing, job, and the screening for TB is not on top of the priority. So we try to see how can we put the screening for TB among the priority of those target people, to make sure that as they go through their journey, include this screening as part of their journey so that they don't feel this is a burden. That's why we're working now with HealthPoint to see how we can expand our referral process so that we can offer transportation, other resources to have those people to connect with a primary care doctor if needed, so that they can continue their treatment if they already initiate. If not, to see if they can screen again and start a treatment for those not screened yet. And because our goal is to really to ease the process for some screening to care and for the rest of the service. That's why our community navigators are really intentional by connecting. We're working with the navigator at Half Point Clinic to see how we can partner and identify those clients. First, to see that, to confirm that they have a primary care provider, but also to be able to connect them to the service when they need it. And as we look ahead, our focus is to sustain and scaling up this response on TB, because this can be a multi-level intervention, and that requires a participation of all the stakeholders. And that's why we really want to expand our approach and reach out to other communities so that we can together see what's working in one community organization and synergize our effort instead of working on silo, because we realize that in King County in particular, we have many organizations working on TB elimination, but sometimes we don't connect to see how we can co-create or can work together to expand our outreach and be able to provide meaningful service to the community we serve. And that's why our model now is to co-create and now duplicate, because duplicate waste resources, it's something is not especially now that the funding is scarce in the TB elimination area. So we want to make sure that the resources received from our funders or partners are used meaningfully to improve impact and on identifying more cases and linking them to care, because that's the goal for us and for our partners. And last, it's also dissemination, because what we're collecting as information, what we learn from our community, we want to share it, not only in King County, also around the state and other partners, to see if, and compare some results, if they have also they have seen the same trend that we see here among immigrants and the refugees from the DRC in Angola. Do they see the same trend in other communities? So this goal is for us is to share the findings and be able to expand to other community and see what we can do together and strengthen our partnership around TB. Because to me personally, I feel like TB elimination is like an orphan in King County. When not everybody talk about the disease, because people feel, I understand on the Congolese community, people feel uncomfortable because the TB has been always associated with 3 elements: discrimination, isolation, HIV, and death. So people don't want to be associated with TB. They prefer to be concerned if they have high blood pressure or diabetes, but not being associated with TB. So that's something we're working with the community to see if we can change this narrative, but that requires a lot of contribution from everybody. So to close, I want to really thank first the TB Echo project and for the opportunity to come today and share. Like we said in our African tradition, it takes a village to raise a child, and this is an ongoing effort and can be complete without the contribution of the stakeholders. Washington State Department of Health for creating the space for us to be here. Public Health King County, that always been the trigger of this TB elimination, and Freeland Foundation, who had our first funder. We initiated this project in 2024, giving us opportunity to reach more people and to understand, to start from ground up this effort, and also APSHO for continuing supporting our effort of screening, and now this qualitative effort of understanding what's the concern in the community, and also our partner community and faith-based partner. We could not do the work we do now without them, because they provide only space, but also they create a safe space for people to come, because most of the people didn't feel comfortable to come to big gathering, but they always come to the church services. And it's when we partner with pastors and bishops to be able to reach those people during after church services, to have time to discuss and share education material. And those faith-based leaders have been really great, and by opening up the doors so that we can come and work. And also our different partners, other community organizations such as Somali Health Board, that have been really key to help us also, because they have been here for a long time to connect with other community and other health board to see how we can together continue this effort of educate community around TB, especially latent TB in our African community. And with that, I will thank you all for your attention and open for questions. Thank you.